Okay. Um, okay, so welcome everyone. Thank you for coming along. As Anna's mentioned, my talk is called Tools for Life, Data Sharing and Public Health. Tools for Life is a public engagement project funded by the Wellcome Trust, the purpose of which has been to engage the public in a dialogue about the benefits and the risks of sharing their patient data for public health. The project commenced in October 2019, so predates the pandemic, and completes in June of this year. The purpose of today's talk will be to provide an introduction to the project, to some of its main findings, along with an indication of what we intend to do between now and June, including further public engagement activities and a final project event. Okay, before turning to the main content of my talk, I'd like to emphasise that I'm speaking today on behalf of the Tools for Life project team, so I'd briefly like to introduce and to thank the other members of that team. They are Sarah Hargreaves, Research Associate on the project, who's done sterling work on conducting the qualitative interviews. Laura Sabafi, Lecturer in Health Informatics, also here at the Information School. Larry's been key to the quantitative phase of the project and conducted the statistical analyses, and Suzanne Mason, Professor in Emergency Medicine in the School of Health and Related Research, also here at the University of Sheffield. And Suzanne has provided valuable support at key times during the project, not least of which has been enabling access to research subjects and other researchers interested in the topic of patient data sharing. Okay, patient data are an essential resource for the delivery of health services. Their capture, storage and utilisation integral to the direct care of the individual patient, clinical research and the commissioning of new services. In recent years, the digitisation of patient records and increased connectivity have enabled the aggregation of patient data from different sources. In the UK National Health Service, these data sources principally derive from patients' interaction with GPs and others in the so-called primary care sector, providers of planned and urgent care in hospitals and the community as part of secondary care, as well as more specialist tertiary services, for example, mental health. This move towards digitally enabled aggregation has been a boon to health providers and to medical researchers alike, enabling the conduct of patient data analyses at scale and the more targeted development of new treatment pathways and health services. While the digital aggregation of patient data has contributed to an increase in its value to the providers of healthcare services, there has also arguably been some costs and risks to the individual recipients of health services. Some of you may be familiar, for example, with the ill-fated Care.Data programme. Care.Data was a government initiative led by NHS England, which ran from 2013 to 2016. The aim of the Care.Data programme was to create a central patient database linking GP patient data with data from a number of other sources, including hospital episode statistics. Accomplishing that aim would require the extraction and processing of GP patient data for purposes beyond those for which the data were originally collected, i.e. for the direct care of the individual patient. Therefore, a key legal obligation was the requirement to obtain the informed consent of each individual UK citizen. The informed part of the informed consent took the shape of a much derided mail leaflet drop to all addresses in the UK. In 2016, following a stop-start implementation, a GP and public outcry, a Parliamentary Health and Social Care Committee review, and a third Caldecott review, the Care.Data project was officially curtailed in 2016. And there are a number of reasons why the Care.Data project was abandoned, including a lack of public awareness as to the benefits or insufficient, inadequate public awareness as to the benefits and value of patient data sharing, Ethical concerns voiced by advocacy groups, medical ethics advocacy groups around the public's consent and the mechanism by which the public's consent to wider patient data sharing had been sought, legal intensity, and governance and security concerns around the systems and procedures in place for handling and processing patient data, as well as the adherence of organisations to those standards. Among the many recommendations that Dame Fiona Caldecott made as part of her review during that last year in 2016, her review of data security, consent and opt-outs, was that there be a shift in the regime and mechanism by which the public's consent to patient data sharing would be obtained. Hitherto, an opt-in scheme, where on receiving information, members of the public were actively required to opt into patient data sharing, Caldecott recommended an opt-out scheme, whereby the NHS has initially decided on the public's behalf that given certain conditions, typically anonymisation, the application of anonymisation procedures, patient data can be shared within and outside of the UK NHS if the purpose is for one of public health. So that was a shift from previously, hitherto, informed consent to what's called presumed consent. And the NHS has decided, as I said, on the public's behalf, that the data can be used and shared for purposes beyond the direct individual care of the patient. The public has the right to opt out, of course, and any member of the public can do so via the NHS website, but consent is assumed and presumed on the part of health providers prior to the member of the public exercising that right. The recommendation was accepted, and by May 2021, originally it was May 2020, because delayed by the pandemic, all GP surgeries need to have complied with the uploading of their patient data. So it's against this background of a broad consensus as to the value of patient data sharing for medical research and the planning of health services on the other, and on the one hand, and the ethical and governance concerns and costs and risks to the public in terms of respect for autonomy, privacy, legal and governance concerns on the other, which the project, and the Wellcome Project, Tools for Life project, was commissioned. So the overarching aim of the project is to unearth what some of the issues and concerns or remaining issues the public have about patient data sharing. The aims and objectives of the project are to engage patients and the public in a dialogue about the benefits and risks of sharing their patient data for purposes beyond their own direct individual care, to improve understanding of the factors that influence people when deciding to share their patient data. They have ethical concerns, concerns about governance and security, or any concerns which emerge about their own experience or personal biography. To engage patients and healthcare professionals in the production of a set of tools for communicating the benefits and risks of patient data sharing, then to evaluate the effectiveness of those tools at a number of public events or deliberation days. So the aim basically is to, first of all, elicit an understanding of what some of the public's concerns, issues and concerns are with patient data sharing. Do that first, and then develop a set of tools which kind of respond to what those concerns are, perhaps tip the balance away from risk and in favour of value. So translated into research questions, what issues and concerns do patients and the public have in relation to the sharing of their patient data for purposes beyond their direct individual care? What tools can be developed to inform the process by which people deliberate and decide to share their patient data for purposes beyond their direct individual care? How can perceptions of the benefits of data sharing, patient data sharing, be increased? How can perceptions of the risks of patient data sharing be mitigated? And how effective are those tools that we've developed for informing the process by which people deliberate and decide to share their data for purposes beyond their own direct individual care? Okay, so to tackle those research aims, objectives and questions, we adopted what's called a mixed methods approach. Obviously, a number of different ways of doing mixed methods. We chose to follow what's called an exploratory sequential design, the intent of which was to study the phenomenon of patient data sharing, first by exploring a problem via qualitative data collection analysis. That's phase one, where we explored patients' issues and concerns. Then a second phase, in which we took the qualitative findings from the first phase and developed them into a set of measures and a quantitative survey, and thereby tried to generalize the findings from the small set of qualitative interviews and generalize those findings to the UK population at large. Finally, phases 1 and 2 are being followed right now by a third phase, in which we're developing intervention tools for informing public deliberation about the values and risks of patient data sharing. Okay, so I'm going to say a little bit about each of those phases. So phase 1, qualitative interviews. Purpose was to elicit the issues the public have about participants were deliberately diverse, identified from different age groups, gender, ethnic group, level of education, occupation, as well as region, and whether they were aware or unaware of the shift in regime from to presumed consent. Interview design consisted of a range of topics, including what issues before consent to sharing their patient data, why they considered these to be important issues, did they have ethical concerns, did they have concerns about, I said, governance and security and handling of that patient data. We also explored what factors they considered would enable or discourage them from sharing. So we were able to conduct 48 qualitative interviews in all, and then transcribed them, obviously, and then did a thematic analysis in accordance with Braun and Clark's method, a method which many of you will be familiar with. In accordance with Braun and Clark's approach to thematic analysis, the themes emerged from a combination of their prevalence across the data set, along with their keenness to the research question. So the theme, by that, I mean that the theme had to occur across different data items, i.e. across the interviews. In other words, we're not counting frequency of mention of the theme within one interview. Somebody might be very keen on a particular pet topic and talk about it and mention it again and again in one interview. But what's important for us is prevalence, that the same theme occurs across different interviews. Also, the theme had to be key to the research question about patients' issues and concerns. So there could be a very frequently occurring theme, which does indeed occur across the interviews, but it's not pertinent to the research question. Okay, so that's just a little bit about Braun and Clark's thematic analysis method, and the themes emerge from based on the criteria of prevalence and keenness to the research question. Okay, so this is an initial thematic map of the concerns that the public have about sharing their patient data for purposes beyond their own individual care. So there are three main themes here. Theme A was that's about value. In technical and scientific or moral ethical terms, beneficence. I'll come back to that and explain that in a moment. Theme B is a clutch of issues about ethical concerns and the ethical standards that are guiding the handling of patient data within the NHS and between the NHS and other external entities, for example, commercial companies or local councils. And theme C was some governance concerns. So one big theme about value, beneficence, and the benefits of sharing patient data, and two themes about concerns, about ethics and governance. Each theme was divided into Sub-themes, so I'll just say a little bit about those sub-themes as well. Beneficence are divided into ideal and obligatory type of motivation for sharing patient data. Ethics is divided into a number of different ethical principles which are common in the medical arena: respect for patient autonomy, veracity and privacy. And governance was split into different levels of governance: legal, kind of macro level, organizational type governance, and a clutch of security issues. I've tried very to kind of paint those bubbles the size of the theme. So beneficence was the most prevalent. So the size of the bubble is a rough indicator of how prevalent the theme was within the data set. So beneficence was the largest theme, and then within beneficence, ideal beneficence was a larger theme rather than obligatory beneficence. Within ethics, respect for patient autonomy was the key sub-theme and the key moral principle, followed by veracity and followed by privacy, etc., etc. Okay, so I'll say a little bit about each of those different areas. So beneficence, this is about the value of patient data. So the general direction of travel is that the public, as represented by our set of 48 interviews, are willing to share their patient data for the purposes of public health. So they're quite willing to share it for purposes beyond their own individual care. So it's the disposition to act for the benefit of others that was the key virtue or character trait underpinning people's willingness to share their patient data. In other words, people are willing to share their patient data if and to the extent that patient data sharing benefits and contributes to the welfare of others. So this is a kind of, those who are familiar with, have some kind of ethical background, this is a kind of consequentialist approach to ethics. So people willing to share their patient data because of on the basis of the balance of good and bad consequences that flow from the act. In this case, there can only be, well, on balance, there are more good consequences flowing from the sharing of patient data than bad ones. We'll come on to the bad ones in a moment, potentially bad ones in a moment. So as a moral principle and guide to action, beneficence can be understood, defined as all forms of action intended to benefit other persons. So an example of this, one interview said, that's why I agree to share. If there's anything I can do to benefit, it comes back down again if it's going to benefit. That's important. But there are different motivations as to why people might be willing to share their patient data for the benefit of other people. Two main motivations emerge from the interviews. What's called ideal beneficence on the one hand and obligatory beneficence on the other. So ideal beneficence is concerned with purely it's an ideal, it's a standard, something to be aimed at. It's a kind of charitable act, a bit like giving to charity. So it's a benevolent act, but certainly it's a virtue of character, giving to charity or giving or sharing one's patient data, but it's certainly optional. It's not obligatory. So some examples from the interviews of what's called ideal beneficence. Share my patient data in the hope that it would contribute to something being better for someone somewhere. So quite general application. All other people, I'm quite happy if I can help others. Another example, I think if the information that I'm able to provide will assist people in their research and probably improve the treatment of others, then I'm quite happy with that. I'm all for sharing my data if it means it can help with the development of research or help other people in treatment. So it's an ideal, it's a standard, not obligatory, but if it can help others in general, and maybe a more specific application in terms of researchers, then that's all to the good. An alternative justification for sharing one's patient data is obligatory. This has a much more specific application and occurred in the context of people who were patients and felt a duty or an obligation to share their patient data, what's sometimes called a reciprocity-based justification for sharing one's data. So you'd benefited as a patient and you wanted to give something back. So examples of this is, I think, well, the NHS has looked after me and I've been ill. I think I need to share information that helps any research that will help me help other people in a similar condition. Or another example, I'm quite happy to do that because as I look at it, they've saved my life. So I had a letter the other day saying all the usual things that was wrong with me. It wasn't one of those, but their tests are just not good enough yet. So anything I can do to help them out, find a test that's better, I would do anything. So on the one hand, ideal beneficence was the much greater, more prevalent reason, but also people sent a sense of duty, and that's or obligation, because they'd benefited and they wanted to give something back. Okay, so the second most prevalent ethical moral principle after Bennett was respect for autonomy. So this is the first of the costs. So I think my argument will be that sharing of patient data is all well and good. People are willing to do that. That's the direction of travel, but at some cost to respect for autonomy, respect for individual patient autonomy. So we can define personal autonomy as encompassing self-rule. So rather than being governed by others, governing oneself. Self-rule that is free from both controlling interference by others and limitations that prevent meaningful choice, such as inadequate understanding. So in a health context, this typically arises in if you're undergoing a procedure, the doctor will provide you lots of information about the benefits of going ahead with the procedure, on perhaps some of the risks. So it's a very important principle in health context. And there are a number of different aspects or conditions which need to be in place to consider that the patient's autonomy has been respected. And these include intention. There needs to be a connection between what's happening and the actors or the patient's conception of that. So if it was a procedure or an operation, there needs to be a clear idea in the patient's mind between that operation and their idea of what that operation is. Understanding, the patient needs to understand what that procedure entails, and there needs to be a voluntary act, non-control. So, and that non-control relates to both external influences, being subject to power over them from the doctor, or but also internal issues which may prevent them from proceeding with a voluntary act. So, and I think we could apply that also to patient data sharing. And I would argue that in a shift, at least in one scenario, in terms of the NHS, from informed consent and opt-in to presumed consent and opt-out, there's been some lessening. The price to pay for that has been some lessening in respect for autonomy. And I just want to give you some quick examples of why I believe that to be the case in relation to each of those conditions. So tension between presumed consent and opt-out versus respect for autonomy. So I think the major sub-theme by way of prevalence, I've got some quotes here in relation to each of those three conditions. First of all, there's lack of awareness among some members of the UK population about, or lack of awareness or understanding of presumed consent. Somebody mentioned, I don't think people are very well informed about it. So clearly that violates the condition of understanding. The next most prevalent aspect was non-control. So a number of people were saying it does feel a little bit like heavy pressure. It runs contrary to GDPR, which is based on informed consent, solely presumed consent. Somebody mentioned it's a blunt instrument, but even though I know that, I haven't opted out. Blunt instrument in the way that it gathers up and hoovers data from the whole of the kind of population level and doesn't really respect the autonomy of the individual patient. Somebody else mentioned you're left with a feeling it's not defined enough or time controlled in any way. That what you say yes to today is not necessarily what you agree to tomorrow. So a clutch of issues about, is it necessarily a voluntary act? The patient data sharing, if the NHS has presumed consent on your behalf, and intention. So there's not necessarily a clear connection between some members of the public conception of presumed consent and what is actually entails. So somebody said it would be nice to know if I could change my mind rather than being a permanent decision, which I'd have to think more strongly about. So clearly, if not just aware, then have a good conception or image of what the presumed consent model is about. Nevertheless, that said, there are a significant minority of interviewees, and by extension, perhaps the public, that they're quite happy to go along with it, kind of acquiesce in the idea of presumed consent, and for a number of reasons, some negative and some more positive. Somebody mentioned just have to be pragmatic and accept it. Somebody else, it's just a bit of a faff. Somebody's decided on behalf, okay, I don't feel too strongly about it one way or the other. Okay, it's a bit of faff to kind of change that decision and opt out. Somebody was more positive about accepting the idea of presumed consent and said, I feel like it's a good model because if you opt everybody in, people that would probably choose to do it but wouldn't necessarily go out of their way to go on and agree to doing it are involved. Whereas the people that say no, I feel probably have a stronger opinion about the fact and therefore more likely to then just say no. So I feel like it encourages more. So there are minority opinion about people quite happy to go along with that. A way of characterizing this tension might be called might call it soft paternalism. So in this case, the NHS, the father figure has decided on your behalf what's good for you, and you're quite happy to go along with that. Okay, third ethical principle was veracity. And I'd also argue that perhaps wider data sharing within the NHS and between the NHS and other entities, as I mentioned earlier, like commercial companies, local council, has also occurred at the expense of cost to veracity, and I'll explain why. Veracity in healthcare refers to accurate, timely, objective and comprehensive transmission of information, as well as to the way the professional fosters the patient's or subject's understanding. That's particularly the second half of that quote, which I want to highlight. Clearly in information management, information science, we're very keen on the accuracy of information, but also in this context, veracity means the way in which the professional, it could be the doctor, health practitioner, fosters the patient's or subject's understanding. Veracity is important for a number of reasons, because when communicating with others, if the doctor's communicating with the patient, health professional communicating with the patient, NHS as an institution more generally, veracity is important because of the respect owed to persons in context beyond informed consent. So clearly, if you're signing an information sheet, consent form, there's lots of communication between the two parties. But I think in the context of presumed consent and the NHS then deciding where that data, who's that data being shared with, there is a certain lack of transparency and lack of veracity in the sense of fostering the public's understanding about how that data is being analysed, data analytics, for what purpose it's being used for. I don't think the public is really aware of some of those onward issues around wider data sharing and data linking. So there's a lessening in respect, I think, again, owed you would argue, on the basis of veracity, owed to individual patients and members of the public. Also, veracity is important in terms of fidelity. Fidelity in this case means that the NHS in this case is actually carrying out, doing what they say they're doing. So if they say that they're going to anonymise the data, and that's a condition of its wider sharing, they need, I have to have a belief that that is actually what the NHS will do. So veracity and communicating that in a truthful way, truth and accurate way to the patient is called fidelity, and respect and fidelity will add up to trust. So just some quick examples of veracity, and where I think perhaps wider patient data sharing has also been bought at the cost of less veracity, in the sense of a lack of fostering the patient's understanding about what's going on. So somebody's mentioned, depends what the purposes are. I might never know. You don't know. Is that just your record being shared? With whom? I don't know. And somebody else, I'd want to know who it's being shared with and what the purpose was. I mean, it could be being shared with an online retailer for all I know, and I certainly want that. So I'd want some reassurance. So it's a kind of disconnect in terms of the link or path back from how that data is being analysed and shared, analysed and used, and form what kinds of decisions with whom, and the link back to the individual member of the public, certainly. In terms of a couple of those other arguments for veracity, fidelity and trust, somebody mentioned I don't have a lot of faith in the quality of anonymisation. It's stated that on the NHS website that anonymisation procedures, and I personally have no reason to believe that that's not the case, and it's not quality anonymisation, but there's a perception amongst some members of the public that anonymisation may not be as quality as they would hope and expect. And finally, trust. So it's a big leap of trust. It sounds a bit negative, but it's accepting that you can't have trust, actually. I don't think I can be made to trust information sharing, because they don't know what it is until tomorrow. The NHS might include my data in a new technology, known or yet unknown, now on this planet or in the universe. I mean, just carte blanche, that's it. It's almost a game that we think we have a choice. I don't know if we have a choice. Okay, and final moral principle, which is important in terms of order present, perhaps a little bit surprising, a little bit down the list, from respect for autonomy and veracity, was privacy. In this context, in the health context, privacy refers to the value which we, patients, place on a condition of limited access or non-access. So limiting access to patient information, and by extension limiting access to the person that patient information is about. So there may be concerns about a loss of privacy may depend not only on the kind and extent of access, but also on who has access, through which means and to which aspect of the person. So there are a couple of aspects of privacy which cropped up in terms of limiting access to patient data and the person who's provided that patient data. One question was how, and how privacy or limited access to personally identifiable information and persons is maintained. And a second was about who has access, and the difference between general access and specific access by specific persons, specific people. Now, the question of how was this question about the credibility and belief in limiting access to persons via the anonymisation procedure. So as I said, the NHS state on the website that any data, broadly speaking, there are exceptions to it, will be anonymised. But nevertheless, a number of members of the number of interviews suggested to some extent I have to trust the NHS that they're going to keep my data anonymised. Nowadays, of course, you're never quite sure whether anything that's anonymous was ever going to stay fully anonymous. I don't know an awful lot about this, but if something has been anonymised, can it further down the line be identified? So trust in the anonymisation process, whether we think that's credible or not. It would have to be a sort of quality anonymisation. not something silly like just hiding the name from the researcher or keeping it stored with the name on the system. So some perceptions about the anonymisation process, and there'll be scope to be able to explain to the public about what anonymisation is, how it occurs, and try and increase their trust in that process. The other aspect of privacy I mentioned was who. So who has limiting access to patient data sharing by group. So again, it's a matter of perception, I think, perhaps rather than reality. I don't know where it ends up. I don't know where it's going to end if you start letting everybody have it. So yes, I'm a little bit wary. I guess so much of the research that involves medicine and medical records is going to be ultimately ending up with commercial organisations, because they're the ones that are going to be making the treatments. I mean, the companies are getting gain from it, monetary gain from it. But then again, they kept me alive, and it's keeping other people alive. So I don't see a problem with that as long as my information is anonymised. So there was some scepticism about the governance of data by commercial companies as opposed to the NHS care for patient data. And final example in terms of who has access in terms of local council. Some of the sort of helplines that are run and gather data, and on an individual basis, because you need to record it, you may need to talk to the client again, are of such a kind of personal, potentially damaging to that person. And legal aspects are one thing. Possibly you wouldn't want that to be shared any further than the team that are dealing with it. So that's more in a community services, local council context. So you wouldn't want to share that data, have it linked outside a particular team. So there are also some governance concerns. Information governance can be defined as a collection of capabilities or practices, the creation, capture, valuation, storage, usage, control, access, archive, deletion of information over its life cycle. This is more about kind of structural and material issues around information systems and how it's processing information, rather than some of those ideal ethical concerns. And I have to say that of the interviewees are more concerned about organisational level governance and a little bit about security, rather than any of the legal and regulatory issues. That's fairly well nailed down in terms of GDPR and specialist health sector guidelines. It was more about organisational, the NHS, local government systems, commercial company systems, and whether their procedures were in place and whether adherence to those procedures was also taking place. Given those procedures are there, are people adhering to them? I think I'm going to move on a little bit because I want to get to some of the survey stuff. So I can share my slides and come back. So in summary, from the qualitative interviews, interviewees are supportive, I would say, of the value and benefits of wider patient data sharing for public health. And that's based on the good consequences that follow for other members of the public in general, as well as patients' obligations to others in specific patient groups. I would argue that this value is bought at the cost of some decrease in patient autonomy. Depends how important you think that principle is, and at the cost of a lack of veracity and transparency in the sense of fostering understanding about wider patient data sharing in a digital context. And I do think a lot more can be done about fostering that understanding about how data is analysed and used. And there are also the continuing, ongoing kind of perennial perceptions of privacy risks to persons remain, how access is limited, and scepticism about anonymisation. So there's scope for explaining to the public about the anonymisation process, who has access and how that's governed. So that was the qualitative interviews and some of the findings from that. We then conducted a broader quantitative survey, as I said, to generalise those findings to the broader UK public. So participants in the survey were the broader UK public. It was a stratified survey, stratified by age, gender, and geographical region. And the survey design extended some of the main themes from the interviews. So those ethical themes and governance concerns, prefaced by a range of demographic attributes. So we're interested in respondents' opinions on sharing their data for the purposes of improving the health of the population, whether they believed that patient data sharing should be guided by some of the ethical principles which I mentioned earlier, as well as the application of governance standards. And again, we also looked at some of the factors that might encourage people to share their patient data. As I said, it was a stratified sample, the UK population, by age, gender and region, and we received 507 questionnaires back. We did some descriptive inferential statistics as well as factor analyses. So just to run through about some of the key highlights from that broader survey. The data backed up the idea that on balance, the direction of travel, or not on balance, the direction of travel is very much in favour of wider patient data sharing in the digital context. 68% of respondents either agreeing or strongly agreeing that wider sharing of patient data can benefit the health of the population. And that was consistent across gender. There's no significant difference between how males and females feel about that. But there are some variations by age. And I think this is something which came through the survey, that irrespective of ethical and governance concerns, there are some differences in age. So older people are more convinced of the benefits, perhaps commonsensically, to the health of the population than younger people. So younger people need to be more convinced about what the benefits are, or made aware. In terms of public's ethical values about patient data sharing, it's a little bit difficult to discriminate and rank preferences, but in this case, in the survey, veracity topped the bill, veracity and fidelity, which goes back to the idea of fostering the public's understanding about wider data sharing in digital context and how it gets analysed and shared. Respect for autonomy and patient choice a little bit down the list, and again, privacy not as high up the list as you might expect. People really happy, comfortable with sharing generally, but they'd like to know more about it, and they would like to exercise their right to opt out. Again, there are some variations by age. I don't think I have time to go into them, but I can follow up with people if you're interested. Again, there's a broad finding that younger people are less concerned about the ethical issues, but older people are. So there are, again, some age variations. So people are much more concerned about ethical values. The older you get, the more you're concerned with moral principles. The reverse is the case when it comes to governance concerns. So we asked people whether they're comfortable with their patient data being shared with organisations outside the NHS. And there is still a lot of concern about patient data sharing across boundaries and between organisations, interorganisational data sharing. So 34% were fairly or extremely uncomfortable. 1 in 3 were fairly or extremely uncomfortable with patient data being shared outside the NHS. When it comes to data linking, 41% are fairly or extremely uncomfortable about that. So a difference between sharing and linking. When it comes to who that's being shared with and whether people believe that their data will be handled responsibly and their confidence in that, people are fairly confident that the NHS, university researchers, clinical researchers, they have a fairly high degree of confidence or high degree of confidence in the responsible handling of that data by those groups of people, but not local councils. 37% were not very or not at all confident. When it comes to commercial companies, 44% were not very or not at all confident that commercial companies would handle their data responsibly. Interestingly, in terms of age differences, younger people were confident, and maybe a bit about, were more confident than older people. So it's a complete reverse of the ethics. So younger people are more confident their data is being handled responsibly by organisations rather than older people. Older people need to be perhaps find some way of developing a tool, information tool, which increases their confidence in terms of the kind of governance side of things. Okay, we also asked people on the whole, do you think the benefits outweigh the risks? There's a massive vote in favour. 81% of respondents think the benefits do outweigh the risks. But that's importantly, that's correlated with education and with awareness of the NHS national data opt-out. More educated, if you're a degree level, you're more likely to believe that the benefits outweigh the risks. If you're more keyed in, clued up with developments in the medical arena and national data opt-out, and only half of the survey respondents were aware, then that's also going to increase your confidence that the benefits of wider patient data sharing outweigh the risks. So it's not the case of, put that all together, it's not a case of that you make people more aware of what's going on and they shy away from it. No, I don't want anything to do with that. The more that you educate the public, engage with the public about patient data sharing, its usefulness and values, the more willing they would be to share it. Okay, so summary of the survey: ethical concerns, veracity, fidelity, and the fostering of understanding. There are some governance concerns about data sharing, particularly between organisations, also within organisations. It's a perennial issue, again, sharing with who we're sharing it with. Is it staying within the boundaries of the NHS? And who else is it being shared with, and how? And what's the oversight for that? Commercial companies and local councils. I think a really interesting finding coming out of the survey, as opposed to the interviews, was this age variation. So there are general ethical concerns, general governance concerns, but if you contextualize that by age, I think you can come out with reasonable statements. Younger people say they're familiar with data sharing from social media, for example. They're familiar with data sharing, attach less importance to ethical principles, are comfortable with their data being shared, and have confidence that it's being handled responsibly. Older people, on the other hand, are less familiar with data sharing, only have some confidence that their data is being handled responsibly by local councils and commercial companies. So again, some implications for the development of tools in making younger people maybe increase their ethical awareness, and maybe balancing, maybe they're overconfident that the data is being handled responsibly. Older people need to be educated a bit more about the analyses and how it's being used, and finding some way of increasing their confidence in responsible handling of patient data. So the final phase was a couple of minutes on this intervention phase. So given all those findings, we're developing some tools to be able to majorly overcome some of those ethical and governance concerns, and then maybe also think about directing it in different age groups. So by tools, we mean information sheets, digital media, animation, videos. We're developing those now, or in the design phase of developing those, and we'll test those out in small group workshops with patients, health and other professionals. In June, we will then present those tools, invite the public to a large virtual deliberation day, which are running in mid-May, and we will ask them whether they believe that patient data sharing, whether value outweigh the risk. We'll take a kind of baseline poll at the beginning of the day. It will be run across a week, and there are kind of state of relative ignorance or lack of awareness, varying degrees of that. Then we'll present them with different kind of information sheets based on the findings from the project, an animation and a video. Hopefully be able to invite members of an expert panel. They'll listen to that, all those different views, they'll discuss with each other, and we'll see whether there's a shift in opinion before, during and after deliberation. Those of you who are in the information school will be familiar. I've run deliberation days before. My colleague Peter Stordy for the MSc Information Management Programme and school more broadly. This time we'll be inviting an external company who will give access to their platform across a week, and it will run from Monday to the Friday, and we'll nudge people in between. So I'm really looking forward to that. Quite excited about that. Finally, so these are some of the references I'm using, some indicative references about governance and ethics, which I've been talking about. Okay, I'll leave it there. Thank you.